Dear colleagues, this is a manual SICS to guide the beginners of cataract surgery. The superior rectus brittle suture is applied, the ocular surface is thoroughly washed with ringer lactate and povidone iodine. A 6.5 millimeter incision is planned in this immature senile cataract. The cataract is soft and we don't need a larger incision. Now this is how conjunctival incision is made and limbal peritomy is done for the desired and estimated extent. That's it. After this, we have to secure hemostasis. Wet-filled cautery is done. The assistant keeps on putting ringer lactate drops and mild bipolar cautery is done. For experts, this may not be necessary. They can do without hemostasis, but beginners have to take proper measures to do a safe surgery. Now, how to place the incision? This is a mild frown incision which can be managed by a beginner cataract surgeon. Now the anterior leaf or the anterior wall of this sclerocorneal tunnel should be of equal thickness all around from one end to the other end. And so this sweeping movement from one end to the other end is done. Now at the middle I have gone into the cornea. Now I'm going to dissect or make the tunnel on the left side. Go into the cornea and come back. And now the tunnel is to be extended to the right side. This sweeping movements so the tunnel has gone into the cornea for about 1.5 millimeter and behind the limbus for about 1.5 millimeter. And now this is a side port or a paracentis incision at 9 o'clock. The pupil has not dilated well. Air bubble has been applied and trypan blue dye is administered underneath this air bubble. Little bit of adrenaline is injected to see if the pupil dilates little more. And yes, see the pupil is dilating. So in some cases we get dramatic effect of adrenaline. That's it. Now viscoelastic substance is injected into the anterior chamber. So in this way viscoelastic substance has been injected. The visco is applied over the corneal epithelium to protect the epithelium and for better visibility. And now capsulorhexis is being done with the needle itself, with the cystitome. 26 gauge bent needle has been bent to make this cystitome, and this cystitome is being used to do this rhexis. The rhexis tended to extend to the periphery at 7 o'clock, but it has been retrieved. That's it. The rhexis has been completed. And now, hydrodissection is to be done. Before that, viscoelastic substance is injected and the tunnel is opened towards the corneal side. Go to the anterior extent, that is the corneal end of this tunnel, to the extreme end, and then go into the cornea, into the anterior chamber, and cut only when you go forward. And thus you make the sclerocorneal tunnel. Now this is hydrodissection, and with hydrodissection the inferior equator prolapsed out of the capsular bag, and after dialing with the 27 gauge cannula, it has come out of the capsular bag. Now visco is injected in front and behind the nucleus, and irrigating vectis is taken. In this case, I'm going to use irrigating vectis for the delivery of the nucleus. Here it is. The vectis, irrigating vectis goes behind the nucleus, and the nucleus is pulled out while little bit of injection of ringalactate is done in the anterior chamber. Now the epinucleus and cortical matter is removed. I go through the side port and remove the cortex from 12 o'clock to 3 o'clock to 6 o'clock. And now, before this portion of cortex is removed, some viscoelastic substance is injected into the anterior chamber so that the anterior chamber remains formed while I am going through the main incision. Here it is. Before all the visco comes out, most of the or all of the cortex has been removed. Little bit of polishing of the posterior capsule is attempted. And now viscoelastic substance is injected into the anterior chamber. In this case, a multi-piece intraocular lens, a PMMA lens, is being implanted. Here it is. Two instruments are being used, a tooth forceps in the left hand and a McPherson's forceps in the right hand. The IOL, the leading haptic, goes into the bag and the trailing haptic is placed in the bag like this. And now viscoelastic substance is to be removed from the capsular bag and from anterior chamber. Simcoe cannula is being used to irrigate the anterior chamber and the capsular bag. And after irrigation for some time, irrigation and aspiration are carried out simultaneously. That's it. We are towards the end of the surgery. Dear colleagues, SICS, manual SICS has got many more extra steps than phacoemulsification, and we must take adequate care and patience to do all these steps. This is hydration of the side port, and this is formation of the anterior chamber, and now the integrity of the wounds are checked, whether there is any leakage or not, and there is no leakage of aqueous. And now the conjunctiva is reposited to the limbus. It is always better to put a 10-0 nylon anchoring suture at the right end where the first radial incision was given here, rather than to use cautery. Cautery will destroy cells, and it is not sure that it will hold the conjunctiva at the limbus. Now, before tying this knot, the superior rectus bridle suture is removed. A little bit of gentamicin and dexamethasone is injected, and now this suture is tied, and this is going to be a releasable suture, which is very easy to remove while the patient is sitting on the slit lamp at OPD. 3 loops, hold the suture, pull it, and just cut the thread with the needle. That's it. Hope this video will help you in doing your cases, will guide you a lot. Now the speculum is removed and the case is concluded.